So I have to debate and defend the continuation maintenance strategy. And interesting that there isn't a third category to defend, which would be to stop therapy and let the patient rest, which if that category existed, it would have been given to Dr. Sandler to defend. So continuation maintenance. And I'm going to start my argument with what I think is sort of a tenet of chemotherapy for stage 4 non-small cell lung cancer. Since the very first drug was given to the very first patient forever, the tenet for an incurable disease is choose the best initial drug or drugs. Give those drugs until there is an unequivocal evidence that the cancer is growing or intolerable side effects. And it's up to the patient and the oncologist to decide when the treatment has become intolerable or too dangerous to continue. And that is how I was taught to give chemotherapy, and I still think that's the default strategy. And it's never been proven inferior. And I think Tom mentioned that Dr. Sosinski spent a lot of and many others have spent a lot of time trying to figure out if we really ought to stop chemotherapy at 4 cycles. And what I'm going to try and convince you is that while we've never shown that additional chemotherapy may be helpful for overall survival, neither have we shown it harmful, so we haven't actually overcome this default strategy. This is the control arm. This is the control arm for phase 3 until it is proven inferior or there's a real reason to stop other than intolerable side effects. Now, the problem with this issue is that some drugs have cumulative side effects. So cycle 4 is more toxic than cycle 3, and those are platinum drugs, taxanes, and Vincas, and those were the drugs that were used in all the studies that showed we ought to stop therapy, right? Nowadays, we have drugs that you can keep giving and giving and giving, and there's no cumulative toxicity. And last, I'll say that historically, cost has not been an issue in drug delivery in American medicine. So you keep giving drugs, and cost is not an issue. So that's my sort of default. And then you look at all of the evidence. And if you put all of the evidence onto a page, and I'm putting Tom's review article up here, you know, time and again.
You're not debating Tom, by the way.
That's true, but it's a good paper. It's a good paper. In all of the evidence that's out there, continuing therapy when it's working, the trends are always better. The trends are there, okay? So sure, it's not statistically significantly better, but the trends are always better. If the drugs are working, you keep giving them, and it tends to be better, and it's statistically significantly better in terms of at least progression-free survival, which is good. The cancer's not growing, so this is a good thing. You're giving good therapy. It's a good thing to do it. The one exception in terms of trends, I don't have a laser. Oh, yes, I do have a laser, is the Korean study, and that's touted as really a paradigm study where patients got carbotaxol, and then they expressly selected the patients who were responding or had stable disease, and then they randomized them after 2 cycles. They randomized them to 2 more cycles or 4 more cycles, and there was an overall survival trend that was unfavorable. At least the trend was unfavorable to the additional therapy. Where is it? Well, in any case, these are all very close, but the trend, if you look at the curves, but the point I'm making there is that they really might have force-fed that 6th cycle of carbotaxol. We don't know that. So it goes against my paradigm in a way. So the trends of continuing the therapy are all good. And then, as Ram alluded to, the Paramount study looking at continuing the active pemetrexed actually showed statistically significant improvements in both progression-free survival and overall survival. And this data is just published in JCO, I think, EPUB this week, where you see this 14-month median survival if you give PEMCIS and respond and keep giving the pemetrexed after 4 cycles. So the trends are there. There's data that it does statistically significantly improve outcomes. There's another study from Europe starting with cisplatin, pemetrexed, and bevacizumab, and continuing the active drugs. Of course, you have to stop the cisplatin, I think, because cycle 5, cycle 6, cycle 7, it starts to get too toxic. But you can keep giving pemetrexed and bevacizumab beyond 4 cycles without concerned for intolerable side effects. And Avapril, if you continue the pemetrexed and the bevacizumab, have better progression-free survival than just the bevacizumab. So more therapy is better, more active drugs is better. And then in Avapril, you got the OS curves. Now this was just updated at ASCO, and actually was not, I have to check again, but I believe the overall survival difference was not statistically significant, but they posted a 20-month median. So now you've got patients where they started cisplatin, pemetrexed, bevacizumab, they're responding, and you're thinking their median survival is 20 months. That's great, keep going. The problem with all the maintenance studies, both the continuation maintenance and the switch maintenance studies, is that they do mandate that you stop the chemo at 4 cycles in responding patients. So you're taking the cream of the crop and you're essentially denying them therapy, giving them a placebo, and failing to mandate or specify second-line therapy. So I think in all these studies, you got to be careful. Stopping therapy at 4 cycles, you might be undertreating the control arm, which might account for the survival benefit. And then Ram introduced ECOG 5508, which would, for me, once and for all, it really endorse a switch maintenance approach, by looking at carbotaxol first and then switching to Alimta later. So this is my metaphor. Continuation maintenance is what you're doing at cycle 5. Okay, the patient's responding. And you know who this is? It's Monty Hall from Let's Make a Deal. And switch maintenance to me is like Monty Hall. And basically, you've got a patient, they're responding to therapy, they're sitting there they come to you for cycle 5, and you're like Monty Hall saying, well, you've got this great thing that's working for you, like you've got $100 in your hand, and basically, you can pick door number 1 or door number 2 or door number 3, or you can keep the $100 that's in your hand. What do you want to do? So you could take the pemetrexed, or you could take the Taxotere, you could take the Tarceva, and you don't know what's behind the door. The only exception is if you have an EGFR mutation, or if you have an ALK translocation, or ALK rearrangement, then you know what's behind the door. You're going to respond. So, of course, switch maintenance is the way to go when you have an oncogene that you can target. But if you're switch maintenance Monty, you might get a goat behind the door and lose your $100. So that's my argument for continuation maintenance.